with the context of GDP of healthcare, it's 4+ trillion in healthcare and shooting to 5 trillion in GDP in healthcare. Within that, you have a staggering 63 million, roughly, caregivers. And to your point, it's like one of the largest sort of like workforce along with members and patients. And roughly 600 billion in unpaid care. But a lot of caregiving is a very, very misunderstood term. What do people get fundamentally wrong about caregiving?
Yeah, I think first and foremost that people think caregiving is just helping out. And because it's framed as help, it's undervalued, unpaid, and it's unsupported. Post-discharge is where plans succeed or fail. The caregiver is the front line. If you've got a caregiver who is engaged, willing, able, they see the warning signs to intervene early to prevent a readmission.
The first step that I think a lot of organizations take is, okay, I need to reach out to family caregivers and tell them things to do that will benefit the performance of my health plan. But we have to think about the caregiver as a central character that needs to be tended to so that their social barriers, their needs can be addressed in order that they can actually engage as a family caregiver and we can reduce their burden.
Thinking about from a health plan operation perspective, right? So it seems like this is also a huge educational opportunity. And I could see like even talking to caregiving or caregivers itself, it's a unique skill set, right? That it needs to be weaved into the whole construct providing healthcare. This is going to connect to STARS improvement. This is going to connect to all the readmission cost of care work. And this is really, caregiving is a huge workforce, the core of taking care of the population. If it's done well, it could be huge improvement for the population we serve and a huge cost driver from a positive side. Hello, everyone. Welcome to the Healthcare STARcast podcast. I have with me two incredible women. One I've known for a long time and worked together, Dr. Heidi. Dr. Heidi, welcome to Healthcare STARcast. And Shara Cohen, CEO of Carallel. We've started to know each other very recently. And we are going to cover a very, very important topic. Topic is probably personal to a lot of people, a lot of individuals, including each of us here, including myself, being a caretaker for my parents. We are going to be digging into caregiving. What are the current issues? What are the current solutions? What's the pathway? So welcome.
Thank you.
Great to be here.
First and foremost, I'm going to put the first question, Heidi, Dr. Heidi, just an introduction, right, for people who don't know you. Just as a context for folks, Heidi and I actually worked together at Independence Blue Cross for a few years. We actually worked in managing quality of care for 100K plus Medicare Advantage members in the Philadelphia area. Heidi being a geriatrician, prior to joining Independence Blue Cross for a number of years. So Heidi, if you want to just give an intro about yourself and also give a quick context around caregiving and why you are so passionate about this, just at a high level, that'll be a good start.
Great. Well, thanks, Subbu, for the invite. I would say I came into geriatrics slowly. As I came to medicine slowly. I did not go to college thinking I was going to medical school, but I did grow up in a family where my father spoke often and told stories about his growing up in a family in rural Ohio where his father, grandfather, great-grandfather were all rural physicians. So it was probably in the back of my mind, the idea of becoming a doctor, but it wasn't foremost. I went to school to be an anthropologist or something like that. I ended up taking a lot of science classes, loved those, then became pretty career-minded. I first thought I wanted to be a nurse. And then someone said, no, the doctors always tell the nurses what to do. This is before NPs became a wonderful career option. And, I ended up going to med school. And it wasn't even in med school that I thought about geriatrics. I wanted to be a family doc. Then there were too many things about being a family doc that just didn't settle with me. Surgery, dealing with sick children. I ended up in internal medicine. And then in my residency, really fell in love with geriatrics because most of internal medicine, or a lot of internal medicine, particularly in residency, is taking care of patients in the hospital. And those are primarily geriatric patients. Really, what drew me to geriatrics was really the complexity, this ability to have a relationship with an entire family. The more complex patients were, the more you were communicating with families. A typical day for me was, having at least half of the time spent with family members, particularly with patients with cognitive impairment. So caregiving has come to me really through my medical practice. I shouldn't say I don't have a personal connection. I do have a personal connection in the sense that both my parents died with cancers and were on hospice for, 6 to 12 months. And I flew home to my hometown in Minnesota frequently to be with them. So in that sense, yes, I haven't got that hands-on direct caregiving, but certainly was a caregiver. And that's what's drawn me so much to the caregiving space.
Excellent. Thank you, Heidi. Shara,
Yeah.
so you have a wonderful organization that you started with Carallel. You have very interesting background. It's amazing to know you recently in the industry. I know it's really a lot of purpose behind starting your company. Would love to hear your background for my audience and your path to starting Carallel.
Yeah, thank you. Really glad to be here and appreciate the kind words. I will say I didn't start Carallel. I came to Carallel by lucky happenstance, but like Heidi, really came to healthcare accidentally, or it feels accidental, and have spent the last 25 years working with what we would call vendor organizations trying to support the healthcare system, and in particular, spent a lot of time in the patient engagement space, specifically furthering the notion that people, each of us individually, is the least utilized resource in healthcare, and that people want to be more involved in their care and just really lack the tools and know-how to do so. And so in sort of 2010 on, I spent a lot of time with health systems designing and implementing programs to do that, to reach people outside of clinical settings, to better involve them in their care. And at that time, there was a lot of talk about healthcare alignment, and it always meant, at least in the way I heard it, it always meant physicians and payers, and so rarely the people who were experiencing care. And so at that time, it was sort of mind blowing for organizations to think about communicating with their patients outside of the four walls of the hospital or the clinic. And so, that was a really important journey for me in sort of understanding how healthcare organizations make decisions and the challenges of implementing new solutions in those environments that are so complex. And one of the things that I learned throughout that was when I would talk to frontline staff about what we were trying to do to engage their patients, they would say, "This is great, but," I have a friend who always says, "Let me give you some life knowledge. Let me give you the LK," right? And the LK from those frontline staff members was, "It's not so much the patient that I'm worried about, it's the family that I'm sending them home to, because I can do so much and then they're gone, they're sort of off in the ether, and I'm sending people home who aren't necessarily healthy, they're just not sick enough to stay here. And what is that family dealing with? What do they understand? What resources and tools do they have?" And at that time in what I was doing professionally, that wasn't the problem we were trying to solve, but it stuck with me. And I was introduced to John Banta and Hillary Ebach, who are the founders at Carallel, who had gone through a personal caregiving journey themselves and found it confounding and exhausting and challenging, and sought to do something about it. And so when I joined in 2021, They were really looking for, how do we scale this with healthcare organizations specifically? And so because of that sort of lucky confluence of experience and need, got to join the Carallel team, and that's been our focus, is how do we help healthcare organizations reach and engage and empower family caregivers as an extension of clinical teams, as an extension of the healthcare system, because they really are. Family caregivers are the largest care delivery workforce that we have. The value of the care that they're providing far outstrips what we're spending on Medicaid and Medicare annually. And so trying to just raise awareness of the dependence we have on family caregivers and the need to support them, and then bring to bear tools and approaches that will do it effectively. So always happy to talk about this topic, as you can imagine.
Yeah. Yeah, thank you, Shara. And then thank you for connecting like the transition from the founders to you and how you came in. So
Yeah, I can only take credit so long, you know,
yeah.
it wasn't me.
But let's step back a little bit, right? Just to reframe the scope of the problem and opportunity here, right? So from a personal standpoint, and half of my life I spent in India, and most of the adult life I've actually, spent here in the US. Culturally, right? Place like India, it's actually taking care of parents. It's like ingrained in the culture, right? So if you're not there for the parent, not talking to them every day, like it's a big problem. It's different, right? Obviously, families are different, cultures are different in the US, right? But it's integral part of Indian culture for over a number of years. Things are changing, but and so WhatsApp calls 3 a.m. in the morning, 2 a.m. in the morning is caregiving, right? So the solutions that are going on in India is tailored a lot to the caregiver, right? Although there are a lot of opportunities, in India, obviously, from a public health standpoint, it's tailored a lot, right? People talk to the caregiver a lot. Even signing off forms, etc., is like once the caregiver is done, like people move on. It's still slightly very different here, right? So with that, in context, and with the context of GDP of healthcare, it's 4+ trillion in healthcare, and shooting to 5 trillion in GDP, in healthcare. Within that, you have a staggering 63 million roughly caregivers, and to your point, it's like one of the largest sort of like workforce, working, along with members and patients, and roughly 600 billion in unpaid care. That's measured. That's even probably a lot that's not measured, but let that sink in, right? These are really, really big numbers just from an economic standpoint, right? But let me ask, right? So there's a lot of opportunities with this macroeconomic impact, but a lot of caregiving is a very, very misunderstood term overall, right? So I'll start with Dr. Heidi. What do people get fundamentally wrong about caregiving?
Oh, that's really at the heart of it. I mean, I could list 10 major things, but I would say, and I'll just give you sort of my top 3. I think first and foremost, that people think caregiving is just helping out. Caregiving is often seen as an extension of love or duty, but not work. And in reality, it includes medical tasks, med monitoring, wound care, monitoring symptoms. It involves care coordination, appointments, insurance, transportation. It is constant decision-making and vigilance. And because it's framed as help, it's undervalued, unpaid, and it's unsupported. I'd say the second is that people underestimate the cognitive and emotional load. People notice physical tasks, but they miss the mental monitoring, the anticipatory anxiety, the grief that begins long before death. Often it's the invisible labor that exhausts caregivers the most. And I would say third, they assume that caregiving is temporary or linear, but actually thinking, for example, that it has a clear beginning and a clear end. And that's really not the case. It often escalates unpredictably. Plateaus are rare. And the difference between it and childcare, being a parent and raising a child care where you are clearly a caregiver, is that getting better may never happen. So Shara is kind of sick of me hearing this, one of my old adages, but caregiving and actually being a patient and having a chronic illness is like being given a job that you are not qualified for, you never applied for, you're not going to be paid for, and you can't quit. And it's a monumental undertaking. And I think, in short, what people most get wrong is thinking caregiving is a personal, private problem, but it's actually essential infrastructure that quietly props up the healthcare world. And it runs on sacrifice.
Yeah.
Yeah.
A lot of tough things to kind of unravel there, right? In terms of education, understanding, and also it's also cultural, right? It's also
Yeah.
very cultural, individualistic, depending on like the type of nuclear families, people have. So with that, Heidi gave a good kind of really high level understanding of like the misconceptions out there. So Shara, you're working on scaling your solution to help health systems and the whole ecosystem. What do you see as misconceptions from your customers, right? That when you talk to them about caregiving.
Yeah. Well, I think it's a continuation of a theme that Heidi just said in this notion of essential infrastructure. And, said another way, family caregivers are therapeutic agents. And I think that a lot of the time that you talk to healthcare organizations and particularly health plans, the misconception is that this is a member experience issue. And it is, but that's not all it is, right? And so oftentimes it is a feeling of like, of course we want to do good things for caregivers, but it's not really our job. Or I'm not clear on what the ROI is. And don't get me wrong, everything in healthcare needs to have a clear ROI, but the idea that it is a soft one or that it is just about sort of making nice for caregivers is, I think, is a big misconception. The other thing that I find a misconception is one that it's always it's often a conception that it's the adult children who are acting as the caregiver, particularly when you talk about when we were in our work with Medicare and Medicaid plans, they say, well, it's not our member who's the caregiver. And I think that's a misconception as well. I think, and in a few ways. I've had the CMO of a health plan say to me, well, my Medicare members are actually on the young end of Medicare, so they don't have caregivers. And the question is, to me, those people are actually caregiving for much more elderly parents or to spouses and partners. And so what we see in our data is that about 35 to 40% of our Medicare and Medicaid members are being cared for by a spouse or a partner, not by an adult child. And so what you're looking at is the dual-sided risk of caregiving. And not only are you worried about your complex members who have a caregiver who is at risk, but you're also have a member who is caregiving, and that is a diagnosis in and of itself. And so I think that idea of it's sort of like it's the commercial plans problem about my caregivers is a misconception that we see a lot.
That's super interesting, right? Personal side, my mom, who's actually a primary caregiver for my dad, when I did the visit recently, spent time with them, she has glaucoma. But she never went to the doctor because our primary concern is taking care of my dad, right?
Yeah.
And then I go there, and then we went it was a very simple 2-hour visit. But even that, it was like, it took a couple of years. And then just that small next step is getting her to some basic screening. Yeah, and she's like, no, I'm fine.
Fine. Yeah.
uh,
Yeah.
right?
The stats there, Sue, are astounding. 67% of caregivers say that they delay their own care because of their care. They can't get to it. So the preventative screenings, the maintenance kind of care is left. And then, of course, all of the risks that we fear about decline happens on both sides.
Yeah. So with that, so let's get into this from a clinical perspective, right? So Heidi, so in your experience over the years, how has the landscape changed with, especially with burnout of caregivers? Obviously, it makes logical sense to, Shara's point, delayed preventative screening, all that stuff, right? But in your experience, what do you see are the challenges really from a clinical standpoint that you've seen in managing one-on-one populations and also managing a large health plan population?
Yeah. Well, I would say there are multiple things that have changed who is caregiving and how often, and how much and what they're doing. And I would say, if you just look at longevity, just look at life expectancy in the United States, that has compared from 1901 to even just 2025, you're talking about a difference of 30 to 40 years in life expectancy. Causes of death, 100 years ago were all acute illnesses. You just didn't live with a chronic illness that long. So now people are living with chronic illnesses and they're living longer. The second is that the workforce has changed. If you look at the workforce in even just the 1960s, maybe 35% of women were in the workforce. Now it's well more than 50% up into the 60%. So women who were traditionally the family member who are home, that's changed. So you have multiple adults working and now also having to caregive. And the third is that really in the 1980s, the federal government changed how it reimbursed hospitals for acute care medicine, something we call the DRGs. So now we're going to pay for a diagnosis and not for how long you may or may not be sick. Although I started to be trained in the 80s, I did see a bit of the before the DRGs when I was in my residency, where at the Minneapolis VA, if you lived in International Falls and you needed to come down for a colonoscopy, you might come for 3 days.
Yeah.
That
Yeah.
was not unheard of.
Yeah.
So you can imagine what it was like if you came in with a heart attack, you were in there for a long time. So people are now getting sent home sicker and sicker. Family members are not just putting a thermometer in your mouth to find out if you're okay. They're managing wounds, they're managing IVs with the help of home health. But I tell you, even with that help, it's just instrumental. So patients are older, sicker, much more complex. Families are geographically very dispersed. People are caregiving from across the country. Patients and the caregivers are really burning out. And when a caregiver burns out, patients go to the emergency room. Med errors are increasing, appointments get missed, and the caregivers are really the folks who often who often watching for those warning signs, and those go unnoticed. So that can be an issue. We do know that as caregiver burnout gets worse or their health declines, that actually predicts patient hospitalization.
It's staggering to your point, right? As you were talking about it, my mind went to so many different kind of outcomes, right? That it actually this translates to ED visit, the mental health, challenges, all these different star measures, all the different preventative measures, and longevity and quality of life, period, for the member and the member patient and the family. From a health plan perspective, Shara, like Heidi and I have gone through this together and also separately, probably like go through this all the time. Engaging members from a health plan is a challenge, purely the members itself, right? As we think about the data that health plans have access to and working with the providers and trying to kind of work in the community to kind of really engage the patient and the member community, that itself is huge, right? And caregiving is a key part of this. What surprise health plan leaders or operators, when you engage, right, you actually talked about, some really interesting statistics there. What really surprises them? Or in also the flip question is, what surprises you, right, from
Yeah.
coming in as a solution provider around what data doesn't exist or doesn't exist?
Yeah. I think that organizations and health plan and healthcare provider organizations intuitively accept the dependence, or the importance, I should say, not the dependence, on family caregivers, but these kinds of direct lines between caregiver burden and ED use and utilization or institutionalization of their members, I think is continues to surprise. And maybe a lot of executives are hesitant to really internalize those numbers. But what surprises me is sort of is I think what you're suggesting, which is a little bit of a helplessness about what to do about it. And so one of the things that we hear a lot is, well, we don't know who is caregiving or who their caregivers are, and until we have more of that data, we can't intervene. And maybe this is like a chicken or egg conversation, but until you actually try to reach those folks with a purpose, I don't think you're ever going to have that data, right? You have to decide that you're looking to intervene. The other thing that I think, and we can talk about what that looks like, but the other thing that I think people have to wrap their heads around is the sort of old adage about what's in it for them. I think that healthcare as a whole is very used to assigning tasks, as Heidi said at the outset. It's the job that they didn't apply for and they're not trained for and they can't quit. So we are, to a certain extent, in the business of saying, here are the discharge instructions. You need to go make these appointments. You need to go fill these meds. Good luck to you. Not, do you have an hourly job that you cannot during work hours go and do these things? Or what is your perception of financial stability in your loved one? Or do you even like each other, right? Like, is there conflict within the family that causes disintegration? And so my point being that the first step that I think a lot of organizations take is, okay, I need to reach out to family caregivers and tell them things to do that will benefit the performance of my health plan. And that is not a way to win the involvement and good feeling of the family caregiver. And so I think, certainly I'm on a soapbox about this, but we have to think about the caregiver as a central character that needs to be tended to, so that their social barriers, their needs can be addressed in order that they can actually engage as a family caregiver and we can reduce their burden.
Yeah. And sure, I mean, thinking about from a health plan operation perspective, right? So it seems like this is also a huge educational opportunity, continuous educational opportunity, rather, across the board, whether it's the call center, starts with consent management. Just the normal consent management is a nightmare right now, right? With a lot of the compliance rules and all that stuff. And also the mistrust that over time, the healthcare system is created with some, segments of the population. And I could see like even healthcare workers, people who are clinician or non-clinician, talking to caregiving or caregivers itself, it's a unique skill set
Yeah.
that it
Yeah.
needs to be weaved into the whole construct of providing healthcare. And I don't see that's actually that's definitely needs to be on the radar clearly. To your point.
Yeah, and but I don't think, we talk about how the scale of the challenge. I don't want to be on the side of saying it's, this massive change, or it needs to be for those who are engaged with patients and members today. And so, your point about the HRA enrollment forms, agents and brokers are talking to family caregivers all of the time. How can you capture that information? Oftentimes when we talk to case management teams, they say, well, we know who the family caregiver is. but it's buried in a note in an unsearchable portion of their portal.
Mhm.
You know, the patient, or I should say the member experience mapping that happens today just needs a tweak of, where are these points along the way in which we might be interacting with a family member that may or may not be the POA, but that we can serve with additional connectivity and create a relationship. And that doesn't have to be we need to retrain
Very
all of
true.
our teams about how to
Mhm.
talk about X, Y, or Z issue.
Good point. Good point. So let's transition this to a specific category of population, right? This is around population who have dementia. This is something that personally also my grandfather was, dementia, and I've actually seen my grandmother going through this for a number of years. So I think it's interesting. Is 7.2 million Americans 65 plus with Alzheimer's. Let that sink in. 12 million dementia caregivers. And then there's a lot of stat around like unpaid care, right? So the numbers obviously are there, but I know there's actually a interesting CMS innovation model, around dementia. Let's start with from a clinical sense, right? Heidi, dementia caregiving, obviously very unique from a clinical perspective, but if you can add a little bit more color to this,
Yeah.
right? That, just for what does it take? Give us an insight into like the burden and the needs of dementia caregiving.
Well, I would say the challenge of providing good dementia care to the family really starts actually with a diagnosis. And there are several pain points for that in the United States. Number one, we just don't have enough geriatricians, geriatric psychiatrists, neurologists, dementia specialists to actually make the diagnoses. And in addition, those doctors who could potentially be making the diagnosis don't, like other primary care doctors, family doctors, internal medicine. Some of them, a good percentage of them, don't feel confident in making the diagnosis. But even when you've made the diagnosis, which involves literally using the caregiver as the historian, because a demented patient really often cannot tell you what is wrong and may even try and hide some of their symptoms. So it's not necessarily a cut and dried, oh, you have dementia because I did this blood test, or like you have diabetes because you have a high blood sugar. It's not a simple diagnosis. That's one challenge. But I think primarily the biggest challenge is that once the diagnosis has been made, it is the trying to explain to families and families come to grips with the fact that a patient's symptoms are not what they consider to be physical. If you have pneumonia, we know what your problems are because you're short of breath or you have a fever or you're coughing. When you have dementia, you're asking the same question 12 times a day, or you are suspicious that your neighbor is having an affair with your husband. Things that are not really what we think of as physical. And that, for many families, just basically pisses them off. They said, oh, I know that they don't mean it, but, I think she's doing this to bother me. So it is a real challenge to get people to understand that the behavior is a symptom of a disease. And then once they've understood that the behavior is actually a symptom of the disease, that's when it starts to dawn on them, oh, I am really losing my loved one. This is the person who had this personality for me before, and now they are this. And seeing that progressive decline is absolutely devastating to caregivers. So it's a very challenging disease to manage from both the clinician's perspective, patients, and the caregiver's perspective. And I would add to this, there's a beautiful model of care that's now really become somewhat of a foundation in good geriatric care in the United States called the 4Ms, where we focus on what matters for the member, what medications they're taking, how mobile they are, but also on their mentation. And that model of care, which we call the age-friendly model of care, in the demented patient really can't function without caregiver engagement. So lots of unique challenges with dementia and caregiving.
Yeah. So, Shara, how does your Carallel platform and your company approach dementia, the uniqueness compared to the other aspects?
Yeah, I mean, it really, I think, is a step building off of a lot of things that Heidi has mentioned. The progressive nature, the unrelenting management of symptoms, the emotional taxation on that changing relationship, and just it's a personal story for me as well in family members who are currently dealing with it, and those that we've lost, and I think it's hard to understate the exhaustion of dealing with the 12 questions a day or the accusations when you're living with the person, and it just is every day, every hour. And so that what's different, or what we have to think about, particularly for caregivers that we support caregiving for somebody with dementia, is just a hyper focus or a magnified focus on their own well-being, on their own encouragement and self-care, and the experimentation that it requires to help them with strategies that will manage those behaviors or help them cope with those behaviors. We do work with a great group called Plans for Care that developed over 2,000 non-pharmacological strategies to intervene and to help with dealing with caregiving that caregivers can control. The challenge is that you really have to, okay, I'm having this issue getting mom or my wife to eat. Okay, well, try this, come back, let's see how that worked, let's try something else, and then it shifts. And so the longitudinal and unrelenting nature of dementia is just means that we really need to tend to that caregiver's well-being in a way that's different than, let's really talk about low sodium diet for somebody who has CHF, which is challenging in and of itself.
Yeah.
But you put that together with dementia, and you got a lot to juggle.
Yeah, I want to add one thing, and that is, you just triggered something, Shara, and that was, there is a reason that one of the sort of Bibles of caregiver information and education, put out like in the 70s, is a book about how to be a good caregiver for a dementia patient. And the title of the book is The 36-Hour Day.
Interesting. I'll vet that. I'm going to look that up, Heidi. I want to transition into what keeps a lot of health plan leaders, operators at night now. Cost of care, quality, all that together, right? Cost, is a big challenge. And we have seen not only in the MA world, but other plans, there's a huge pressure on that, right? With the aging population, a lot of demands. So let's jump in around how do we see caregivers impacting some of these direct impactable measures that impacts cost, quality, you name it. So I'll put this question to Shara first. So what do you see from a data standpoint, in Carallel, the relationship between the caregiver support and the readmissions data? So
Yeah.
getting readmitted to the hospital, preventing readmission to the hospital is one of the biggest drivers, right? And I'll come to ID on the clinical side, but I want to just start from the data side. It's like the bottleneck is, right? So where do you see the current gap is, and where do you see, how do you help
Yeah.
clients in connecting that bridge?
Yeah, it's really important. And we sort of started off with what is the ROI? Utilization in general, ED use, readmissions, admits, is preventable. Readmissions and use often comes down to the family caregiver. So we talked about the reduction in length of stay and how people are discharged from the hospital earlier than ever. I would argue that the best remote patient monitor we have is that family caregiver, if they know what signs and symptoms to look for. And so I think the disconnect is that people are sent home with a stack of papers. If they're sent home with a stack of papers. And I want to let's give everybody the best benefit of the doubt that every time I've gone to the hospital, somebody tells me a bunch of stuff in clear language. And then I go home and I don't remember anything that they said. And then I have a question about something that's in the paperwork or I've lost it. And maybe I know to go into the portal to check, but that's not a small barrier for a lot of folks. And so the coaching and follow up with the family caregiver is a readmission prevention strategy. If they know what to look for, or they're asked the right question, they know what's going on with their loved one. The flip side of that is we see that people are sent home and then they're told home health is going to come. And so out of fear and unfamiliarity, they just wait. So there is a lot of data about people showing up in the ED because the caregiver is exhausted and just wants somewhere to put them for a few hours. There's a ton of data. UPMC did a study that showed that when they intervened with caregivers at discharge, they reduced readmissions by 25%. We have a tendency to say it's a process issue, or if I just put the right technology, send everybody home with a scale, then we're going to fix the problem. And a lot of this is just a human problem that we need to address. And the family caregiver can be the linchpin to that. So proactively, prior to the discharge process, figuring out who those family members are, helping them understand what's going to happen post-discharge, checking in on them to make sure things are happening is a readmission strategy. It is not a nice to have, like, wouldn't it be, don't people feel better when they're supported? It does impact those cost measures and is not terribly complicated. It just takes a little bit of will to do it.
Yeah. So Heidi, if you have the best caregiver for your patient, just giving you the best case scenario here, right? Let's say and let's say the data is also clear whether it's you're part of the provider or let's say your clinician team or you working with the member. How does that help you? Let's put it, how does that help you just in reality, right? What happens?
Yeah, I mean, post-discharge is where plans succeed or fail. The caregiver is the front line. If you've got a caregiver who is engaged, willing, able, they see the warning signs of when to intervene early to prevent a readmission. They help get the new prescriptions. They understand the changed dosages. They understand potential interactions. They help coordinate that very quick and soon follow-up, a 7-day appointment with a provider after they've come out of the hospital. This is, perfect case scenario is you have a caregiver who is engaged and supported, because it's, as Shara mentioned, it's very uncommon to see someone who knows everything. I as a physician, as a geriatrician, I was a caregiver for my mother when she got discharged from the hospital. And I tell you, my family relied on me intensively for all clinical things. And I just can remember thinking, wow, I'm so glad my mother has me. But most people just don't have that.
Yeah. So let's put that in a best case scenario flip side, meaning let's say the caregiver has the best experience with the doctor and the health plan, right? How does that translate into real patient or member satisfaction from a CAHPS standpoint? Your thoughts, Heidi?
So, I think from the clinical side, when families feel heard and supported, they really rate their care higher. Even if there are bad outcomes, most people understand that the healthcare world is complicated. They're not expecting cures. They're expecting to be heard and expecting to be supported. And what they're really expecting more than anything else is they really want a partnership, not just service delivery, so to speak. And I think the plans, for example, that include caregivers in all their care planning basically see that in their CAHPS scores.
Yeah, and I would add on to that, I talked to a plan recently who said that they found that over 40% of their members relied on their caregivers to fill out forms, right? So
Yeah.
when you ask their opinion of the health, when you ask the opinion of health plan, it's often the caregiver's opinion, right? And so those CAHPS questions are heavily weighted, and we've seen with multiple customers when they do their mock CAHPS surveys that there's a difference between members who have been part of, or their caregivers have been part of a caregiver support program across multiple domains.
Yeah. And I'm so glad that finally CAHPS transitioned to email after decades because it was always hard, when the paper goes somewhere and like it's hard to kind of give that to the caregiver, right? So now
Yeah.
there's an email.
Yeah.
There's always so we've actually come far. But let's talk about the medication adherence part. This is a day out conversation that I have with my clients, prospects across the industry, right? It is a challenge as we speak right now. It's 2026 on the STAR side. This year is single weighted, and it's going to go into triple weighted soon because the medication adherence is going to be risk adjusted this year. But still, this is always a heavyweight problem from a cost perspective, clearly on the STAR side as well. So, Heidi, bring us to here, right? So, what are the critical things that the caregivers can truly influence medication adherence?
Yeah. Especially for seniors who have cognitive decline, I would say caregivers are essential with patients who have complex medication issues or have complex regimens that they take at home. Caregivers are managing pill boxes. They're managing all the pharmacy contacts and refills and renewals. They're oftentimes the front line to notice a side effect from a new medication. We do notice that patients with early cognitive decline actually can look completely normal in the office, but then challenge them with something that's complicated, like how to take their medications, and that just falls apart. So the caregiver is really responsible also for the administration of the medicines, making sure that they're taking their pills. And when you don't have good caregiver support, those adherence interventions really, really fail.
Yeah. And Shara, how does your platform connect to influencing adherence here?
Yeah. Well, it's, at the I'll call it the identified point of need, as Heidi's described. It's really giving people tools to help in that administration and management and organizing and affording meds. I would say even before that, though, a lot of times we talk to caregivers who say, I feel like I know this is coming for me, but what should I be doing? What should I be looking for? And one of the things that can help those folks that are early in the caregiving journey is when you're at your mom and dad's house, look in the fridge, look in the medicine cabinet, get to know like sort of what is going on, because people are caregiving long before the care recipient is willing to acknowledge that they have a caregiver, right? And so just watching for, I'm sure a lot of folks who might be listening to this have the experience of opening up their parents' bathroom cabinet and finding a whole pharmacy in there, right? And what has been left over from old prescriptions that they still have in the mix there. There is a whole sorting that the family caregiver can do, or at least risk identify for primary care providers that like, hey, why is my mom on all 16 of these things? And they may or may not know that mom has all those things. And so that when we say they can be the patient monitor or they can raise red flags, that's what I mean is, know what to look for and ask for help in intervening.
So let's shift from what you said, Shara. You said a couple of things interesting from a caregiver standpoint, opening up the fridge, looking at it, it's a great example, right? We all go through it, especially caregivers. And for health plans, you mentioned looking at call center notes, looking at, like your agents have talked to the caregiver, like how do you translate that data into people who are actually taking care of the population once they are enrolled into the plan? So similar to that, what are the different signals? Where should plans start? Because it's an infrastructure problem, and there are some tweaks we can do to get it started. It doesn't have to be millions of dollars of investment. We have to start somewhere. What are the other signals that people have to look for from a health plan or a health system perspective?
Yeah, I think that, we've named a few who's interacting with case management, care management today. And that is a hugely important piece of this because those are your highest risk folks. But, we want to capture the rising risk. We want to have a better understanding throughout. And so to your point, these moments across member experience where you can capture who helps you. If you, in case of emergency, who would you call? You'll notice I'm not saying who's your caregiver. There are questions to be asked to capture those relationships as that are less charged in the vocabulary than the idea of having a caregiver. And it works on both sides, right? People who are care recipients often say, my daughter does all of these things for me. My husband does all of these things for me, but they're not my caregiver. It's my husband, it's my wife, it's my daughter. And so that can be stigma on their side. On the flip side, I'm not a caregiver. I'm just doing the thing that my husband needs. So that's an important piece. And then look at other data that's indicative of caregiving needs. So certain DME orders, certain diagnoses, certainly the combination of diagnoses that would rely heavily on caregiving, and do proactive outreach to those members and families. And so oftentimes it's the caregiver that's opening the mail, that's answering the phone, that's doing all of those things, even if they're not the documented POA.
Yeah, those are some awesome thoughts, Shara. So Heidi, from a clinical standpoint, right? So imagine 200,000 of population of a health plan, right? So got, limited reach. You got your customer service, utilization management, care management, and other teams who are engaged, whether it's actually with the member, patient, or with the provider. How do you think about stratifying caregiving burden, right? So what are the different, whether it's disease states or where do we start?
Well, I think you start with strategizing from the perspective that caregiver burden should be stratified like chronic disease risk, so that it needs to be multi-domain. And what I mean by multi-domain is, you want to take a look at things like care complexity. How complex is the care that's being provided? What's the availability or the role strain on the caregiver? You want to take a look at the resources that the caregiver has, and you want to take a look at the emotional burden or the psychological load that the caregiver has. So you stratify patients in terms of have it be multi-domain, have it be dynamic, have some kind of trigger where it's responsive, and then directly tie those risks to tiered interventions. I mean, if anything less just basically turns screening into, like a documentation theater. That's what it needs to be. It's critical to actually have caregiver burden stratification for a plan.
Awesome. Shara and Eddie, you've given 2 or 3 practical thoughts for the industry, right? Just basic stuff starts. It's early in January. I would say it's not early in January. It's wrapping up, right? By the time this episode is out, so we'll be wrapping up the first month. This is also for the listeners, for people who are long-term going to be in Medicare Advantage. This is a long game. And for folks, there's also CMS has put out an RFP or RFI around improving Medicare Advantage for the long term. The due date is January 26th. This is a time to kind of put things in perspective on what can you do this year, next year. Take Heidi and Shara's thoughts here. This is going to connect to STARS improvement. This is going to connect to all the readmission cost of care work. And this is really the core of taking care of the population. Caregiving is a huge workforce. If it's done well, it could be huge improvement for the population we serve and a huge cost driver from a positive side. So it's been an incredible conversation. I'm sure we can talk more, but I wanted to give one final closing question to each one of you. So Heidi, from a clinical perspective, any last thoughts to share for people to hear around caregiving?
Yeah. I would just say from a geriatrician's perspective, trying to speak to health plans, caregiver is not a caregiver strategy is not really just nice to have. They are part of the team, and it is something that health plans need to pay significant more resources for, because it will pay back in volumes to them. You support caregivers, you improve outcomes. We know this. Ignore them and interventions will fail. I mean, this isn't really just clinical, this is operational.
Awesome. How about you, Shara, from a business perspective and a product perspective?
Yeah, I think it's a variation on the theme, right? That the ROI on engaging caregivers is real and measurable. I think it, as Heidi has said, the centrality of caregivers to clinical delivery and by extension cost, I think necessitates a real strategy. And I think most organizations, unfortunately, or the starting point that we can build from, have put a series of links on their website and a couple of articles and referred people to national resources that may or may not be able to help them. And so I would say that, my closing thought is we are assigning caregivers more and more homework. And if we can actually actively help them get the work done and reduce that burden, you'll see that ROI across. It's a diffuse benefit, right? It creates ROI across, as we've talked about, cost and utilization, STARS, experience, but it is, I think that makes it all the more important.
That's awesome, Shara. My takeaway, hearing both of you and in this conversation, I'm really even more energized, I would say, because there's a lot of innovation that could happen here, on the caregiving part. And, it excites me that this is another, really from a technology perspective, but also from a cohesion of the overall, healthcare ecosystem working in conjunction to kind of really improve care. So thank you for joining, both of you. And Shara, where can people follow you, and any conferences you're going to?
Sure. Follow me. Yeah, I'm on LinkedIn. I'm Carallel.com. Happy to take these kinds of conversations offline. All the usual industry conferences and the like.
Excellent. Thank you both, Shara and Heidi. We will hopefully do a version 2, I guess, at some point, but hopefully see you in person soon. Thank you.
Yep, great. Thank you.